Well, hello everyone. Thanks for joining us tonight. My name is Jay Flanagan, and I would like to welcome you to tonight's NSGC consumer webinar. Presented title is Fertility Preservation an Option for You? Sorry, I was having trouble moving that slide. We encourage you to ask questions throughout the presentation. If you have any questions you would like to ask our speakers, which is myself and Dr. Wald, who I will introduce in a second, click on the questions and answer tab and type a question in the chat box. Questions submitted will be read aloud during the question and answer portion of the presentation. By submitting a question, you are consenting to have the information contained in the question read aloud during the presentation. Please do not submit any personal identifiers in your submission. Please note, as a courtesy to the presenter, all participants' telephone lines have been muted automatically. If you should experience technical difficulties during the presentation, please utilize the question and answer tab to submit your questions or concerns our way. NSGC offers a wide range of educational programming. The information provided in this presentation is not a substitute for medical or professional care, and you should not use this information in place of a visit. Call, consultation, or advice of your physician, genetic counselor, or healthcare provider. It is my pleasure to introduce Dr. Wald. Dr. Wald, can you introduce yourself?
Sure. Hi, everybody. Thanks for inviting me to be here. My name is Tiffany Wald. I'm one of the reproductive endocrinologists at Sanford Health and the University of South Dakota Sanford School of Medicine in Sioux Falls, South Dakota. I have been here for about 5 years, and Jay and I work very closely together in our reproductive medicine clinic. It's a fairly clinical practice with a lot of teaching and some clinical research as well, so a little mix of everything. I did my training in medical school here in South Dakota. I did my residency in Kansas and fellowship in Boston, Massachusetts, so I've had a little bit of experience with moving as well. So it's nice to be back. It's nice to be here, and thank you all for listening.
And I'm Jay Flanagan. I'm a genetic counselor. I work along with Tiffany at Sanford Health in Sioux Falls, South Dakota. I've been a genetic counselor for about 14 years, and I've been at Sanford that whole time. In the last probably 8 or 9 years, most of my clinical time has been spent in this clinic. And so we work very closely together on many different avenues, but this is one particular topic that has become more near and dear to my heart. So thank you for joining us. Want to give just an overview of today, what we're talking about. This is not going to be super in-depth. So if you want to know everything about fertility preservation, we obviously want you to go speak with your physicians about that in more detail. But we do want you to know a little bit about what this is, because it's not a topic that actually comes up all that often. And we're finding more and more couples could find value, or individuals could find value from having this conversation probably much earlier in life than they are having it. So the first half of the talk, Dr. Wald's going to talk a little bit about fertility preservation. She's going to talk about some of the options that are available and obviously some of the costs that go into it. And then the last half of the presentation, I'm going to talk a little bit about things that you should know about your family history related to reproductive medicine, and potentially some of the examples that we would talk with patients about fertility preservation if things or topics came up in their family history. And then for the last half of the seminar, we're just going to do questions and answers. So hopefully we get a bunch of chat questions that we'll be able to answer. So please feel free to write those in at the end of this conversation.
Okay, so we'll just start a little bit with the basics. What exactly is fertility preservation? It really just means preserving either eggs, sperm, or reproductive tissue. So usually the ovarian tissue or testicular tissue, so that a person can use this in the future to have biological children. You may hear the term oncofertility as well throughout this talk, and that often refers to fertility preservation for patients with cancer, and that was coined not that long ago, and comes up pretty often in the literature. Ovarian reserve is an important topic as well, and it's important because for women, egg number and in quality will decline quite a bit actually over time. And this is different in comparison to men who in general will regenerate sperm about every 3 months. There's some changes with age as well, but not as marked as compared to women. So what things impact egg number over time other than age? Well, certainly environmental exposure is a big one. Certainly is tobacco. Any sort of cancer treatment, chemotherapy, radiation, surgery. And we can look at some markers for oocyte or egg number with hormone levels, blood work, simple blood work, and ultrasound monitoring. This slide is frequently used, or this graph, in many talks by reproductive folks really over the past many years. And the numbers really aren't that important. I think what's important is if you look at the trend in the lines over time. So fertility for women really peaks in the 20s and then starts to slowly go down. And somewhere around mid-30s, that slope gets much steeper. And this doesn't really matter where you live or what your race or ethnic background is. That's pretty similar among all women. That rate of decline is due to two things. The egg number drops off and egg quality goes down significantly, primarily due to chromosome abnormalities as we age. So, why talk about preserving fertility for women, and what are the indications? I think certainly one of the big ones is women undergoing cancer treatment or recently diagnosed with cancer. Certain chemotherapy agents play a big role with early menopause and put a woman at risk for ovarian failure, or what we call ovarian insufficiency, and also decreased fertility. Surgical treatment also for cancer can pose a risk to fertility, especially if ovarian tissue or a testicle is removed, also from scar tissue from surgery. Radiation therapy also can pose a significant risk for early menopause. There are other conditions that are non-malignant that can be associated with putting women at risk for early menopause or a decline in their fertility. Many autoimmune conditions can do this. Immunosuppressive medications or other diseases that require chemotherapy. Ovarian disease such as severe endometriosis, recurrent cysts, something called ovarian torsion. And then there are certain genetic conditions that put women at risk for premature menopause as well. And I think Jay will touch on some of these, but Fragile X and Turner syndrome are two that we see fairly often. And then there are personal reasons as well for preserving fertility, and often this is age-related or just a personal desire to delay childbearing or certain social situations. So what kind of things are available? Well, the treatments that are readily available and not considered experimental at this time, fairly standard treatment would be IVF or in vitro fertilization with embryo freezing. That's when we fertilize the eggs in the lab. And that can be done either with or without what we call pre-implantation genetic testing, which we'll touch on a little later. There's also IVF with oocyte or egg freezing, and that's a nice option for women who may be single, who don't have a partner, who aren't wanting to use donor sperm, or have moral or ethical concerns with fertilizing eggs. Ovarian transposition is when we move the ovaries out of the pelvis or away from the area of radiation. So that's a surgical procedure, fairly easy to do and could be done at most locations. Hormonal suppression. Oh. Lost my slide there. Hormone suppression. Thank you.
Okay.
Can be done during chemotherapy. There's a medication called leuprolide or devolupron, which is used to suppress the ovaries during usually chemotherapy. This one's a little more controversial with how well it works to preserve fertility, but certainly there's some emerging data that's promising in this regard, or at least to help improve ovarian function after treatment. And then sperm freezing has been available for many years and is widely available. Egg and sperm donation, and then also surrogacy, or what we now refer to as just using a gestational carrier. These things are considered experimental, but may be available to some patients depending on the situation. Ovarian tissue freezing is, really we're seeing more and more studies on this all of the time. I think there's well over 100 babies born from this process now, but technically it is considered experimental. The nice thing about this option is it doesn't delay treatment. So traditional IVF treatment usually delays chemotherapy treatment for about 2 weeks in order for us to get the eggs out. Ovarian tissue freezing does not require hormone exposure, so this is a nice option for women who may have hormone-sensitive cancers. This can be used in prepubertal girls. And then the tissue is usually transplanted back into the body, so it can be back into the pelvis near where the ovary was originally located, and that's called orthotopic, or sometimes you'll see heterotopic transplantation, where the ovarian tissue is put back into a different part of the body, like the abdomen or the forearm. And then in vitro maturation is also experimental, but that's when we take out ovarian tissue and try to get the eggs to mature in the lab or in a petri dish. So, what kind of success rates do we see? Well, IVF, or in vitro fertilization with embryo freezing, has been around for many years, and the success rates have really skyrocketed. The way we freeze embryos and eggs now is generally a process called vitrification, and the thaw survival rate has really improved. So we see pregnancy rates ranging anywhere from 20 to 50 or 60% with frozen embryo transfers. Very commonly, depending on the age of the woman at the time that the embryos were created. If we do genetic testing, pre-implantation genetic testing, this can sometimes improve those numbers as well, especially for older women who are at higher risk for chromosome abnormalities. IVF with oocyte or egg freezing has also improved significantly. The caveat with this is it's also very much age dependent. You can see that in the numbers there. And also it requires a fair amount of eggs for live birth. So cumulative live birth rates can be as high as 50 or 60%, but that often requires 10 to sometimes 20 eggs to achieve that. And that's, those numbers are lower for women who are a little bit older from a reproductive standpoint. This is where the concept of embryo banking comes into play, and sometimes it requires more than one cycle. Most of those numbers were generated from women who did not have cancer, and when we look at some of the data with women who have had cancer, there appears to be perhaps a slightly lower live birth rate, and I suspect that's from a little bit lower oocyte quality at that time. But nonetheless, it is still an option for those patients, and they should be counseled on that. Sperm freezing for men is widely available. We can use that sperm down the road either for intrauterine insemination, which we call IUI, or in vitro fertilization, which we just talked about. Generally, that would require ICSI. That's when we inject one sperm into each egg to help with the fertilization process. And pregnancy rates, again, for this are very favorable. IUI pregnancy rates are a little bit lower, but IUI is also much less expensive and less invasive for the couple. So that may be a good option for some people. The costs with these sorts of treatments are highly variable, but in general, IVF with either egg or embryo freezing can cost anywhere from $10,000 to $20,000. It can be covered by some insurance companies. There are about 15 states that have a mandate for insurance coverage for fertility, and 3 that cover it, I believe 3 now, for oncofertility patients, patients with cancer who would like to pursue fertility preservation. We live in a mandated state in non-mandated state in South Dakota, so the vast majority of our patients end up paying out of pocket for this. One of the drawbacks is it does delay treatment for about 2 weeks, but that's improved a lot. In the past, it used to be 5 to 6 weeks, so now we have newer stimulation protocols to kind of streamline things, so that's gotten much better. There's some hormone exposure for patients, and this can be a concern for women with hormone-sensitive cancers. So, for example, breast cancer, which is probably the most common thing we see. But again, we have some stimulation protocols which help lower the hormone exposure for them, and actually very reassuring data over the years showing really no increased risk or minimal increased risk in recurrence. There's some yearly storage fees for the eggs and sperm and tissue, but it's fairly nominal. And then there's the option of what we call PGTA now, or PGTM. It used to be called PGS or PGD, pre-implantation genetic screening or diagnosis. This is to test for aneuploidy or chromosome abnormalities in the embryo. So I wrote here at the blastocyst stage, it is typically done on day 5 or 6 of development of embryos in the lab. So this is after fertilization, which of course requires an egg and a sperm. But this is a nice option for some patients depending on the situation, and particularly for patients who may have a single gene disorder, for example, with breast cancer and BRCA. So I'm going to hand this over to Jay.
All right, well, thank you. So the last part here that I'm going to talk about are the things that a genetic counselor may talk to you about in an infertility setting or in a setting of fertility preservation. Most people don't think of a genetic counselor being involved in these kinds of conversations, but over the course of time, I found that it's been quite valuable to be part of this team because it's really hard for me to counsel somebody about one of these situations without a physician being there to work as a team member. But I also find that patients in our clinic do value the opportunity to have these conversations. And so there are many reasons to see a genetic counselor, but in this case, want to talk through just some of the potential reasons that we might talk to a patient about fertility preservation. So the first thing is I always think it's important to review your family history. I often kid patients that they should go to Thanksgiving and talk about semen analysis with their family members because it might get a kick out of them. But more importantly, sometimes it's important to ask some questions about fertility because it actually may lead you to understand more about your reproductive risk. You know, are you at risk to have things like early menopause? You know, were there family members who had a bunch of miscarriages or even potentially stillborns? You know, and then there are some, you know, things that are more relevant to genetics, like where there are diseases that appeared in the family history. Is that something that we could be thinking about preventing? but also things like cognitive handicap. While that doesn't seem related necessarily to fertility preservation, one of the more common reasons for early menopause or early premature ovarian insufficiency is a condition called Fragile X. And so I'm showing you that here. I don't want to spend a great deal of time explaining how Fragile X is inherited. We could spend a whole hour just talking about that in general. But as you can see, individuals who are carriers of Fragile X have an increased risk for premature ovarian insufficiency that may be around 20%. So about 1 in 5 people who are carriers of Fragile X will have this particular issue. Now, that's not to say that if you have some type of ovarian dysfunction that you are a carrier of Fragile X. That's really important because we don't want people to think that that automatically qualifies you to have Fragile X. That said, if you do have some types of ovarian dysfunction, it may be worthwhile to consider that kind of testing to give you a little bit of an idea about risk for the future. And the risks are really twofold. One, is it going to be difficult to get pregnant, but also it's potentially possible to have a child with one of these inherited conditions. And is that something you would like to talk about further? Another thing that we oftentimes talk about here is chromosome issues. Turner syndrome is the most common condition that we would pick up. That's where a woman doesn't inherit both of her X chromosomes. For some reason, just one was inherited. Actually, one thing that's more typical in our particular setting is we see individuals who have something called mosaic Turner syndrome, which means some of the cells of the body actually appear to be normal, and some of the cells of the body are missing one of the X chromosomes. People who have mosaic Turner syndrome may not have all of the features that you see online if you're Googling this, but they may actually be at increased risk for other issues, including issues during the course of pregnancy. And so it would be a conversation we would want to have before we even go down this road of either talking about fertility preservation or even talking about doing some treatments for you. And then there's maybe a little bit more controversial, but even things like other inherited genetic conditions like BRCA may have some issues related to ovarian insufficiency. Another thing that I would talk with you about if you were coming to see us is just talking a little bit about just some background information before we actually get into the conversation about what we're going to do. So again, is there any relevant family history? In addition, everybody in the family should, or every couple should be offered certain tests. And one of the tests that we offer everybody is what's called carrier testing. Carrier testing just means that we would look at you and potential partner and see if there's a risk factor that you could have a child with any of the conditions that are listed. In the old days, meaning 5 or 6 years ago, we would just test for 1 or 2 inherited conditions. And today, with how easy genetic testing and cheap genetic testing has become, we're testing for more and more conditions. Some panels include well over 100 different conditions. In terms of coverage, it can be quite variable based on location, based upon types of insurance you may have. Some insurances are quite good at covering this type of test. Some insurances consider this to be completely elective. But some of the questions I would want to ask you before you even proceed with this type of testing is what do you think you'll do with this information? Would it change anything for you? Will you continue on with your current management? Would you consider doing something like PGD again, testing embryos to see if they're affected? Is that an option for you? Or, are you just looking for more information, and how will that information affect you moving forward? In terms of this particular topic, some of the things that I would want to talk about are just age. As you get older, particularly for females, there's an increased risk for infertility, there's an increased risk for miscarriage, there's an increased risk for things like Down syndrome. Those are the things that you typically see on the internet. There's a paternal age risk effect. It's a little bit hard to measure, but definitely something we would talk about. And then the time to get pregnant is increased primarily because of the first 3 things that we talked about up there. I also would like to draw your attention to this picture here. This is actually what chromosomes look like if you were to look under a microscope. And as you can see, as an individual's age increases, how those chromosomes align becomes problematic. I usually talk about how the machinery of the egg breaks down over time. And so instead of those chromosomes lining up nice and orderly like we would expect, they can become kind of random or stochastic. And when they become that way, it becomes harder for the cell to separate those chromosomes, which can lead to too much or too little information being passed along. Along with age, one of the things that I think is really important for couples to think about, or women or men to think about, is some of these questions here. How many children would I like to have? Seems like a fairly obvious question to most people, but when they start thinking about it related to their age, that can be a fairly complicated question. What age are you hoping to start at? Are you hoping to have a career? Are you hoping to have other things in place before you start a family history? Do you have enough time? I'll come back and talk about that. Do you have a partner currently? Are you afraid that your fertility is nearing an end, but you haven't had children yet, and you would like to potentially have a child using someone like a donor? And is a donor an option for you? And what does that mean if we use a donor? And then when should you consider future fertility? You know, should you start considering fertility when you're 25? Should you start considering it when you're 35? And so just an example that I might talk about with a couple who's 37, for example, is they may come to us and they've been trying for a while to have a baby and it hasn't been successful. And Dr. Wald will go through and talk about all of the different options in great detail with them. And then many of our couples will say, you know what? Let's just start with the very simplest thing that we can do, and then we'll go from there, partly because of cost, partly because it feels more natural for them. But one of the questions I usually just want to ask a patient is what is your dream? What is the dream for you and your partner to have in terms of number of children? And if a 37-year-old woman thinks to herself and says, you know what, I've always dreamed that we would have 4 babies. And now I'm really worried that, that isn't something that we can achieve. Now, we can't say that any of what we're talking about is going to be a guarantee, but one of the things we want to talk about is maybe the option for you is something like doing IVF and banking embryos and putting embryos away for the future, whereby you could store embryos now and prolong your fertility. A lot of couples also come into the clinic thinking, well, I saw this actress on TV and they got pregnant at 50, so it must be possible to get pregnant at 50, without recognizing that the reason they got pregnant may be because of the issue that we're talking about here, or potentially even using donors as an example. So it's really important to have this conversation around not just what can we do, but what are your future dreams and goals. In addition, many of our patients, as Dr. Wald talked about, come to see us because of cancer. From a genetics perspective, some of the questions I would ask was, were you recently diagnosed? Were you given the option of fertility preservation? Sadly, but very importantly, many people who are of reproductive age are not given the option of fertility preservation or have not been talked about that particular option. I think that's becoming more common that people are being talked about it, but we still do hear many examples of people not given that option. In addition, did someone talk to you about genetic testing? So oftentimes now, if someone's been diagnosed with early breast cancer, for example, either an oncologist or a surgeon or even a genetic counselor will visit with you about the potential possibility of doing genetic testing. And if you were to go on and do genetic testing for something like BRCA, would that be something that you would want to think about testing an embryo for? Is that something that you're concerned about passing along to the future, a future child? And is it possible that we could potentially help you with that option? In addition, as we already mentioned, there are certain genetic predispositions that may increase the possibility of fertility problems. So again, if a person is found to have a BRCA mutation, even if they don't have cancer, say, they have a family history, mom was diagnosed with breast cancer, she tested, she was positive for a BRCA change, and now you've been tested and you're, say, 25 to 30 years old. One of the questions becomes, could that potentially be a risk factor for you to have children in the future? And should we start to have some conversations around the possibility of fertility preservation for you? And then lastly, we've alluded to this a couple times, so I just wanted to point it out. We have now come to a point in time where we can test embryos for certain things. We're not at a point yet where we're changing genes or we're doing things or manipulating genes to the point where we can give you a baby with the right hair color, eye color, anything like that. Primarily what we're doing when we're doing this testing is trying to find embryos that give you the best chance of having as healthy a child as we can possibly give you. And so the first test up there is what I still call pre-implantation genetic diagnosis. There's now a more scientific term, PGD. But in this particular case, as you can see, what we were testing for, we looked on that last column and found that that first embryo there is actually unaffected. And so that's an embryo that we potentially would want to use for potentially transfer. But in the second one, we found they were also unaffected, but in a carrier state. And in that particular case, that might be the second embryo that we would actually use to transfer. And then oftentimes there are other embryos that are said to be affected or have chromosomal issues. The bottom is the one that's actually kind of mind-blowing. When you start getting into this field and you start looking at embryos, it's actually fascinating how many of the embryos are abnormal. Whether you're 20 years old or 40 years old, there tend to be some embryos that are abnormal, and as you get older, it seems like more and more of those embryos become abnormal. As you can see here, this is actually a woman who was in her 20s. She had 3 embryos that were normal out of 8. Some of the reasons that this potentially could be important to you, it can prioritize what embryos we transfer, making it easier for our physicians to have a conversation with you about what is the best embryo to put in. It also reduces how many embryos we are putting in. Instead of putting 2 or 3 or 4 embryos, we might just have a conversation with you about putting 1 embryo in because we know the embryo we're putting in has the right number of chromosomes. In addition, this testing can test for things like Down syndrome. As you can see, an embryo with an extra 21 is what Down syndrome is. That may not be something that you would want to do or may not be something that you would consider wanting to do, but for many couples, it is something that they might want to know. And so this technology also gives us the possibility of doing that. But in terms of this conversation that we've been having, the reason why this could be relevant is if you are banking embryos for the future, and you were to do this testing and you found that you had 3 embryos that have normal chromosomes, and you want only 1 baby or 2 babies in the future, you might feel very confident with this report and feel confident that we would have the number of embryos stored for the future. On the other hand, if you were a person who would say, I'd really like to have 3 or 4 babies in the future if possible, this would maybe argue that we would need to do another IVF cycle and hopefully gain some more additional embryos that were normal for the future. So it gives you more of a heads up versus if we didn't have this information, we would have 8 embryos and we would just think, I hope that of those 8, there's some embryos that are normal. I hope that there are some that would be good for the future, and there probably would be, but we would have less of a knowledge about what those particular embryos would look like. So in terms of our information, those are the topics and things that we wanted to go through with you tonight. I hope you found some of that valuable, and I hope that you took away something from that. We want to pause just for a second and give you an opportunity to write a chat question. We'll wait maybe about 30 seconds to a minute, and then we'll start with a question and answer portion of the conversation. All right, as you guys are thinking about a question to ask, just one more thing I just want to mention before we start there is, here I just want to say, start the discussion. A lot of times it's kind of hard to know where to start. Where do I find the right specialist? Who's the right person to talk to? We just encourage you to talk with your primary care doctor. If you have an OB, they're a great place to start. In many places, you can actually get directly to a reproductive doctor. If you call their office, they can schedule you an appointment. You can talk to a genetic counselor, and they could help you find a specialist in your area. We also want you to think about having a conversation this holiday season with your family about diseases and health and potential concerns that are noted that may give you some clues about thinking about your future fertility and things that you would want to do. And then finally, just don't delay. If you have a real recent diagnosis of cancer, you're getting up in the 30s, or you have family history of certain genetic things, it might be better to have a conversation sooner than later. The sooner that you have these conversations, the more likely Dr. Van Wald can help you with the treatment options that she was having a conversation about tonight. Okay, so we're going to start the question and answer portion of the conversation. And so I'll start off with the first question that we have tonight. All right, this question is, I am 38. I'm not currently in a relationship, but I've always wanted to have a family. What options do I have? Would you like to take that one?
Sure, I'll take this one. So at 38, this is a very common scenario in our office, actually. This is a perfect situation to talk about IVF with egg freezing, especially for a patient who is not in a relationship. We always would offer the option of donor sperm and fertilizing the eggs and freezing embryos if somebody is open to that and wants to go that route. There's, as Jay talked about before, with the number of chromosome abnormalities and egg numbers decreasing, particularly around the age of 38, actually. We always talk about 35 as that magic number. That's sort of an arbitrary cutoff. Where we see it really probably decline significantly in IVF is, I would say, more around 38. This is the time to have that conversation. So we would just start with some ovarian reserve testing, ultrasound, some blood work to get a better idea of basic or baseline fertility potential for her, and then counsel her on that option.
And from my perspective, if a donor was potentially an option for you, one of the things that I would talk about is looking at the donor banks and thinking about, picking a donor in terms of family history, in terms of, what testing has been done on them versus what testing we should potentially think about doing for you. Do you have concerns about their family history? Most of the time, the family histories are quite benign, but they might have a family history of cancer. You might have a question about that. So there would be that conversation that I would have with you as well.
The next question is, does long-term storage or freezing affect the risk of chromosome abnormalities?
Gonna take it? Yeah, go ahead, start with that one, end.
Okay, we can both take this one. My answer to that would be no. We don't have any data that really shows that. Sometimes the outside of the eggs, if we're just freezing eggs, can be hardened a little bit with the freezing process, and we need to do, when we go to fertilize, do a process called ICSI with the sperm. But I'm not aware of any good data showing an increased risk of chromosome abnormalities from long-term storage. Jay?
Yeah, I've not seen anything either. And in fact, if anything, if we store early, we think that the chromosomal issues are gone away, if you will. Whatever the risk was at the age that you were is the risk that they are now. We believe that if we test embryos and they're normal, they would maintain that. Even after we thaw them out. So I have not seen anything that would change that risk. To date, I don't perceive that we'll find that in the future. Okay, next question. I have had multiple family members who went through menopause at a younger age. I'm not sure what that age was, but what should I do? And so you want to start with that one too? Yeah,
I think we would both see this patient and talk to you. That is something that's very common. Early menopause is highly familial. Meaning if your mom or your sister went through early menopause, you're at a much higher risk for that as well. It kind of goes hand in hand with the age of the first period. Actually, that term is called menarche, is also very familial. But for early in, what we define as early menopause, by the way, the average age of menopause for Caucasians is 51. There's a little bit of difference with other ethnic and racial groups, but in general, let's just say 50. Anything below 40 or before 40 is in general considered abnormal or early. And so that's when there's an increased risk of some issue. So whether it's genetic, autoimmune, or what have you. So especially with a family history, I would certainly offer some testing, and I'll let Jay talk a little bit about this, but usually it involves chromosome testing and probably Fragile X. You want to take over?
Yeah, I mean, I think we mentioned that earlier, that there's those two options. We have actually found a fair number of people who are carriers of Fragile X with a family history of early menopause. Most people think there has to be, a boy in the family history that has mental retardation, because that's the first thing that you think about when you think about Fragile X. But in many of the families, there wasn't a boy, or the boys in the families happened to be not affected, or this issue with how many repeats the boy has to have in order to be affected hasn't gotten to a point yet where it's manifests itself. And so we're looking at mostly the recurrent risk of premature ovarian insufficiency or failure. So that would be definitely one thing. There's more and more information coming out about other potential genes, other potential risk factors that potentially could be risk factors for having early menopause. Most of those are fairly rare, though, and so we would have to take a family history and start evaluating what's actually going on and what we can find out to order one of those tests. But those also might be an option for some people, and as testing come down, it might be more and more of an option for folks moving forward. This is another good one. I'm glad that we have this one. I have a recent diagnosis of breast cancer, so we've already talked about that some tonight. No one has discussed this option with me yet. What should I do?
So this is a hard situation, and one also that we see pretty often, and particularly in women in their 30s, I would say, and early 40s. The treatment for breast cancer has changed over time, but the first thing that typically happens is if it's a recent diagnosis, often the plan would be to figure out what the treatment plan for would be, and also to discuss fertility preservation. If chemotherapy is going to be needed or used, which often it is, most of the time the chemotherapy used for breast cancer is fairly toxic to the ovaries. So there's a pretty high risk of ovarian insufficiency or failure after chemotherapy, especially for women who are a little bit older. I would say certainly mid to upper 30s. So we often will talk about IVF with either egg or embryo freezing as quickly as possible. We can do these random start protocols where we essentially start anytime in the menstrual cycle. It takes about 2 weeks for this type of treatment to be done, but it would delay any treatment as far as radiation or chemotherapy for that time period. For patients who really, really want to do something and freeze tissue but cannot delay chemo, then they might be candidates. You might be a candidate for ovarian tissue freezing. That is not offered at every institution. It needs to be under research auspices. But there are several places that have that. I think the other thing that's very important with this is the genetic counseling component, particularly for example, the breast cancer gene or BRCA gene. Jay, I'll let you talk on this a little bit, but for women who are carriers or affected with the BRCA gene, if we freeze embryos and cryopreserve embryos, we can do genetic testing of the embryos to identify if the embryos have been affected by that mutation. So this is, of course, a little controversial. Not everybody wants to do this, but it's a autosomal dominant disorder. So in general, about half of the embryos would be affected. And that may be something that patients want to know. Jay?
Yeah, I mean, it used to be that, generally speaking, it wasn't something that was talked about or even thought about, but in the last few years, it's become more and more of a conversation that we're having with folks, and a lot of women are thinking about that particular option. A lot of women have gone through and seen family members die of breast cancer and seen the tragedy that has come with it, and they're just looking for a way to not have to think about that for future generations. And so we would want to have the conversation and just figure out, is that meaningful for you? And is that something that is something we should consider doing? And it may be where we don't have time to test the embryos up front. And so we'd have to have a conversation about what that would look like, potentially freezing the embryos and testing them at a later date. If there was time and we could do it on the front end, we would try to do the testing before we froze them the first time. But again, that would be a conversation we would have to have, because a lot of times we're kind of we're in a time crunch to get everything done, and we may not have all of the options in front of us, but we would definitely want to have that conversation. So
yeah, absolutely.
Okay, one of our questions here says, does any freeze and thaw issues affect embryo or function that we know of?
I'm just rereading this here, sorry. Does any freeze and thaw issue affect embryo and function? Not to my knowledge. So the way we freeze and thaw embryos is now with the process called vitrification. I think almost all labs have gone to this. The thaw survival rate has improved dramatically. When I was in training, it used to be about 50%. It is well over 90% now, probably in most labs, for embryos. Egg thaw survival rates probably aren't quite that high. But eggs are a little more sensitive to this because they're primarily made of water, and so ice crystals can form. That's much less of an issue with vitrification. I guess I'm not quite sure on what the question is with function. If you want to clarify that in your question in the chat box, that would be great. But implantation rates have improved with this change in technique, I guess, if that's what you're asking about.
One of the things that I oftentimes will bring up with families that are thinking about or have read things on the internet is that in the old days too, before there was any knowledge about what actually was happening at the chromosomal level of the embryo, many of the embryos that we had frozen actually had chromosome issues. And so it wasn't necessarily always the function of the freezing or thawing that was the reason why we weren't having success. It was that we were taking our one or two or more of our best embryos and doing a fresh transfer with those. And so the ones that we had in the storage were not necessarily embryos that were good or potentially even had normal chromosomes. And so as we have moved along and we've actually found embryos that are normal chromosomally and froze them, we've actually found that they have very high success rates after transfer. And in some cases may even be more successful than fresh transfers. And so we've had a lot of success with vitrification. And I think we're still not understanding all of the reasons why an embryo is good or isn't good. But as of right now, just with chromosomes alone, knowing they're normal has really made us feel like the freezing thawing has much lower risk than we've ever thought before.
Right, I agree. We have a question here on how many successful and failure cases are there. That's hard to quantify, I think. I will tell you where we've seen the most improvement in rise and success has actually been with egg freezing over the last, I would say, 10 years. It was considered experimental probably up until about 5 years ago. And again, with the older method, the thaw survival was just not very good, and it took multiple rounds to achieve even some embryos, and just with a very low live birth rate. So I wish I could tell you it was 100% for everybody. I really, really do. The truth is it's not, but it has improved significantly over time. And I think the other thing to keep in mind is what's a normal fertility rate, right, for humans. So it's not 100%, it's about 20% each month. So if you took 100 couples, women all age 30, for example, only about 20 or 25% would conceive each cycle if they had no fertility issues. So when we talk about IVF pregnancy rates at 20 or 30 or 50 or 60%, that's really in comparison, that's per cycle, it's really in comparison to normal fecundity or fecundability, so pregnancy rate per cycle for humans, which is around 20-25%. For younger women, it's actually lower than that once you get above 35.
And related to that, the question was what ages are successful even with frozen embryos. So I think there's two questions there. How does age play a role in this? And second, does age affect when we transfer frozen embryos?
Does the age of the recipient? Is that the question?
I think so.
Okay, I'm going to interpret it that way. And the answer is really no. There's some impact with maternal aging over time in regard to there's some higher pregnancy risks. There's greater risk of gestational hypertension, the need for a C-section and gestational diabetes. But the implantation potential of that embryo is the same really as the day it was frozen in general. So for example, if you froze the embryo at age 35 and transferred at age 45, the success rate really would be about the same as somebody who's 35. There are reports, of course, that you maybe have seen on TV or in magazines of much, much older women in their 50s and even 60s having frozen embryo transfers. I would say that's not common. And most fertility clinics have some upper limit of where they maybe set a threshold on transferring for various reasons, psychosocial aspects or the maternal risks to the pregnancy. But I think from a purely physiologic standpoint, most of that is related to embryo health and age.
Okay, looks like we have one more. I'm only 25, but I sometimes worry I won't be able to have kids. I'm not sure fertility preservation is for me, but is there anything I can do now to determine if I should consider it in the future?
Oh, that's a great question. So I had mentioned briefly some testing we can do for markers for ovarian reserve or markers for egg number. These things can be done for women not trying to conceive as well. The predictive nature of those tests in patients not trying to conceive is perhaps not as well shown, but I think it's still a good place to start. So things like a blood test called AMH or FSH, or just a basic ultrasound with something called a follicle count can be very helpful. And just talking to a physician about your health and a genetic counselor, hopefully, about your family history and any risks you may have. Because, for a lot of patients, they may have some things that put them at risk that they don't even or aren't even aware of. Where freezing or considering doing fertility preservation at 25 would be a good idea, and for other patients, it may not be necessary for a while.
And I would just mention, just generally health. We're not a real healthy society at the moment. And so even things like weight gain or diet or things like that can be significantly important, both now, obviously, and in the future. And then, weight gain also can have issues physiologically with hormonal functioning and things like that. And so are there ways to maintain a healthy diet, maintain a healthy weight, or even get to a point where you're having a healthy diet or healthy weight could also significantly impact our ability to help you achieve pregnancy in the future, or for you to get pregnant in the future. So, okay, it looks like that's it for tonight. So I just want to thank everybody for attending tonight. Thanks for the questions that everybody wrote. That concludes our webinar, and thanks for spending some time with us tonight.